does lead us in nicely to what Susan's going to talk about. So Susan has been practicing a long time and completely understands about the problems picking the right compression and using evidence to treat the leg that's in front of you. And we know that these legs are really quite complex, that we're seeing none of them are just cut and dry, really the same thing. They can have a real mix of signs and symptoms. But I think that just before we go, I think that would bring us to our next poll, actually, which is talking about choices. But Mahmood, did you have a question?
Very, very interesting discussions, and it's really fascinating to learn more and more, always with such a discussion, because I think what Dr. Adam mentioned about the fear of some colleagues of using different compressions, talking with different patients, especially the diabetic patient. In 2017, there was, I think, the first controlled randomized study done in the US by Professor Stephanie Hu in Chicago. She did a really good study about using the mild compression, 18 to 25, with lower extremity edema in diabetic patient. And in this study, it was really, really interesting to see the significant decrease in the edema and also protecting the legs, especially the diabetic patients. Once they get a wound, sometimes it's really, really hard. Depend also on the awareness and the hygiene and the other things that the patient are facing. So I think it's really important to work on increasing the awareness among the different healthcare providers when it comes to use the compressions. They shouldn't be afraid at all, as Dr. Adam mentioned, because it has a significant effect. Maybe, as Helen mentioned, that it's really important to choose something fits for them. And here the sizing, the measurements playing a crucial role in that, but also choosing the right materials and the right things fit for their daily use. And then patients will be more compliant, and then the result, of course, outcomes will be more and more significant. This is just one comment I would like to add, because the study, I think it's available. We can also share it. It's available also at our Medical Online Hub platform. So I encourage all the attendees to go through the different documents and the materials. It's free access, and you will find a lot of studies referring to the same topics.
Brilliant. So now, thank you. Yeah. Great, and that diabetes should never be a barrier, should it? So that's great. Really interesting study. Thank you. Great. So let's have a look at the next poll question, can we? So yeah, should it be based on evidence-based decision? 83% say yes, which is great, isn't it? But how do you get everybody aware of the evidence behind every product? It's pretty tough, isn't it, to do that? So Susan, I'll let you tell your story about what you did to try and change, where Zigbar supported you with this, about how you could really help practitioners of any level, vascular consultants, nurses on the ground, practice nurses, anybody, how they can make an evidence-based decision about what they're going to do for their patients. So did you want me to show the slides out, or do you want to have a talk about it first?
No, I think just a quick thing. I have been in nursing for a while, a few years, and when I came into the community in the early 80s, leg ulceration was a rarity. Yeah, and we had no compression at all, and we had no idea what we were going to do with them. Obviously, Christine was doing her work in the background, but that didn't hit the compression, didn't hit the community till a lot later. But the complexities have changed as well, and I think part of the initial problem we have is that the original guidance was that you had to have an APBI before you put any compression on at all, as a form of bandage. And that has seemed to have stayed, and we need to get rid of that, which is really good. We look at the National Wound Care Guidelines, which recommend that as long as you exclude some red flags, you can safely put on, the 15 to 20 millimeters of mercury compression as a starter. and then get round to the assessment, and then commence effective management, which, as Adam has said, that's the biggest problem he sees. And I know Helen sees it because we've talked about it so many times, that by the time we see them, we already have a more complex patient. The wound is harder to heal because of the congestion, trying to shift the fluid so you can get better perfusion to the wound bed, and managing everything. And the patient's in a mess and they don't want to comply sometimes, they don't want to get involved. There's a lot of abdication and responsibility. And there are wider issues in the community at the moment. The Queen's Nursing Institute have highlighted how 46% of district nurses will be retiring in the next 5 years. So we're losing a vast amount of experience. And so we're ending up with a very serious skill mix, which I'm sure that Adam and Helen will have seen, where they don't have the background knowledge. And this has bothered me for a long time. And also with the increasing complexity of patients, which is why Care and Compress started on my kitchen table, really. So if you wanted to put the first slide up, please, Katie. Thank you. That's there we are. So Guest et al. Has been mentioned, and I think it was a real shock at the time. I can remember the very first study that I was at Queen's UK when they released the first study. I don't know if Helen was there, I can't remember. But everybody gasped at the figures, and they wanted to see the article so they could read it. And more recently, Phillips et al. Have produced a similar study looking at patients in Wales and then extrapolating that information. We don't seem to have made much of a difference, to be honest. It's really sad. We've got this evidence out here, and I think it's not through lack of will. It's the NHS, although it's supposed to cover the whole of the UK, and it does, it's a very mixed bag. Every area is different, and quite often people talk about postcode lottery. So for patients, it can be quite, their experience can be quite different depending which area they're in, as to whether they have a specialist clinic, where they get, some people go straight into a leg ulcer clinic if they've got anything below the knee. Other people are managed in the community solely. And so, the other thing I think we mustn't forget is that it's not just about venous leg ulceration. Adam and Helen have mentioned chronic edema, lipedema, and obesity. And as I said to you earlier, Katie, most of the people that I see are female at the moment, and they're obese. And most will have, type 2 diabetes as well. They'll have chronic venous insufficiency, and they'll have lipedema. And, if we could get some early intervention in, that would be really great. So going on, sort of looking at the garments and how do we choose them, that has always been a problem. And as you have said, there are so many garments out there. And so I had a long conversation with a colleague, Tracy Green, and we wanted something initially that was quite simple to follow. But we also wanted to provide the evidence. So in the original document, as with the new one, we looked at what we wanted to include, and we included legs on wounds, venous insufficiency, chronic edema, lymphedema, and lipedema in this flowchart that we created. And we then gave diagrams, instructions, guiding people through sort of the mild, moderate, and severe cases, and giving suggestions of, obviously it's a Sigvaris document, so it has Sigvaris garments there, but also what we wanted to do is to make sure that we didn't talk about class, we talked about the levels of compression, which I think is really important, so people understand how much compression they're providing at the ankle with the garment. Because there is that confusion, as Helen said earlier, about British Standard Class 1, and then you get what some people call European, which isn't European, it's RAL or AFNOR. levels of compression, which are different, as we both know. So the idea with this is that you look at pictures, you follow it through, you are able to identify the patient's condition, and you see the recommendation of level of compression, suggested garments or wraps that you need to do. And on the back of the garment, there is a whole list of the latest or most relevant bits of evidence, so that we're encouraging nurses to actually, when they have time to read, not just to take our word for it, but to actually go and question, to understand why compression at a certain level works, you know, and how wraps work and how bandaging works and all the other things. And you know, obviously we've also included the National Wound Care Guidelines red flags as well. So we've updated it. So it is actually, it's got everything in it at the moment, I hope. So
it's completely updated, Susan, because the National Wound Care Strategy is developed over time. So we've always made those adjustments. So it's always clinically relevant and up to date with the most latest evidence. So there is a section in there, the front page, which talks about the red flags and what the nurse or doctor is able to apply to the leg without a Doppler in the absence of red flags. And it even suggests a garment which gives, you know, 15 to 20 millimeters of compression, which is the most you can have without a Doppler.
Yeah.
Even a Welsh version we have now too.
Yes, because their red flags are slightly different, aren't they? So yeah. For those people who are watching in Wales, you have your own document and the rest of the UK has the standard one. So talking about the use of this document, it's sort of gone a lot wider. Initially, it was just for nurses, but I find it being used in different areas. Some doctors have taken it up, physios, dermatology, and that sort of thing. So it's seen quite widely. But it's also very useful for patients. And not that they pick it up and diagnose themselves, but as a guide, because sometimes patients need to be involved in decision-making. And I think we are still guilty sometimes of taking control. I know what's best, you do this. And that is sometimes a bit of a problem because patients want to feel responsible. Some don't, but some still do. And thinking about a gentleman who is aged 80 years old, and he had been relatively healthy. He looked after his wife. She had dementia and then had died. And he was lonely, and he had a history of over many years of venous leg ulceration, which he had treated, and he religiously wore his stockings. He took care of his legs. His skin was in good condition. And if he had any concerns, he was seen by a practice nurse. He made the decision, because he was lonely, to go into a nursing home, because also he found that he could no longer put his stockings on. And so by the time he was admitted to the nursing home, he had developed varicose eczema and the early signs of edema around the ankle, which, because he had scar tissue there in previous ulceration, he was at high risk. All he had to do is knock his leg, as we know, then you've got a big problem. And so because I had been involved in the training in the home, and they were aware of the National Wound Care Strategy, they phoned me, we talked it through, because I didn't live next door. I had to arrange to go and see them. So they went through the document, they assessed him, they decided he was safe for 15 to 20 millimeters of mercury compression. They put it on. I arranged to come and do a full assessment. I felt that he was safe to continue with full compression. But what were we going to actually put on him? Now, the nurses probably were quite keen just to have a simple stocking, just to put it on. You know, it's done and dusted. But he wanted to be involved. And one of the reasons why he wasn't wearing his stockings is because he couldn't get them on and off. So I showed him the document, and we went through all the different stages, and we looked at all the different, you know, what the recommendation was and what was available to him. And he decided that he would like to try a wrap. He'd never tried one before because he'd always had garments. And his rationale for that was he had a routine he'd used over the years where he always had a bath or shower in the evening and then creamed his legs and then gone to bed, which is really good from a garment point of view, because then all that grease doesn't damage the garment in the morning. And he wanted to continue that, but on days that he wanted to, it meant that while the carers were running the bath, he could actually take his wraps off. Now, he didn't do it all the time, but he had the option to do it. And I think that is really important. I think there is a danger sometimes that for swiftness, we do it. But actually, we should be involving the patients more. So I hope that very small story might be of interest to people. It was very successful. I haven't seen him recently, but I understand he's doing well.
Brilliant. Yeah. And you are really focusing on the patient, and that's where we should be focusing. And I think what we've spoken about today, this early intervention, is so important. And with what Mr. Howard and Helen were talking about, with empowering the nurses to make the decisions about getting early compression on their patients, and preventative care also, get it before. We know that chronic venous insufficiency is progressive, so talking about the importance of early intervention is essential globally, not just in this country. I would love to, I don't know the guidelines in every single country, but I would love to know the maximum amount of compression people are putting on patients in other areas of the world, really. It would be great to get some feedback about what works well in other countries. And I really wanted to share today the National Wound Care Strategy, because it has been a massive success in this country. They've got all the data back, and it is now healing leg ulcers within the 12 weeks, which we should be healing leg ulcers in within 12 weeks and getting early compression on, not 2 years down the line. But we know there's bigger issues at hand with, workflow. There's more patients than there are healthcare professionals, especially if they're trained in it. And what I felt I got from today is that you guys talking about compression wraps seem to be moving forward, where we never used to use them so much. They're going to sort of be replacing more bandages, and they're allowing patients to wash and cream their own legs, allowing them to get their shoes on, reducing their edema, healing their ulcers, and the nurses can step away, but supporting their patients with education. But Adam, did you have a question? You've got your hand up there.
Yeah, for Susan, it was really about patients getting into the bath, because I've always said for years that the patients can get in the shower and they can shower the ulcers down or the bad skin, and I say to them, use Dermol in the shower and use that emollient. And then if they time it before the nurses are coming to the house, I know they don't come to the house so much anymore, and they have to go into the practice to get the dressings, but I think it's really important to get a daily routine so they can have a shower and be clean. They can put on a simple dressing and go to the practice, or wait for the nurses. And as you said, they can take the stockings or the compression off at night, have their shower, their bath, cream their legs at night, and do a really good moisturizing session. And then in the mornings, get their stockings or compression back on. And I think some people can only have carers coming 3 times a week, and they're not sure what to do. And I think it's really important to try and find a stocking applicator that they can use. And there are lots of different types out there. I know Sigvaris has some very good types, but depending on how strong their fingers are and whether they've got arthritic hands and wrists, I think it's really important to try and create a routine for them so that they can actually comply with the treatment. Because I think a lot of these patients, they're not complying with the treatment because they can't. And then they get stuck again, you see, and there isn't the nursing care in the community. There isn't enough nurses to care of this expanding elderly population.
Yes, of which I'm one. We're all getting there slowly.
So yeah, I think that's a very good point, and it's not. We all sort of lump these patients in with the non-compliance, and it's not always about that. It's often they do want to comply. Some don't understand why you're wanting them to put garments on in the first place. So they think, why, you know, you're going to cause more damage putting a tight garment on their leg. But when you explain it to them, and often once they've got the compression on, they actually find that the pain goes often. But it's the education and talking to them and finding out what they can manage, how they can manage it, what aids there are available, how, you know, and there's different ways of putting creams on. You know, we talk about there's the sprays you can get now, and we often talk about you know, get a wooden spoon and put a sponge on it, and you can then go down and cream your legs that way. There's all ways of being able to get the patients to self-care. But I think as nurses, we are often we do take that away from them. It's like, you know, I do that, you do this. And I think we do have to get out of that mindset somewhat. But equally, when we do get out of that mindset, we just suddenly say, oh, well, you can go ahead and do it now, but we don't actually give them the tools to do it in the first place.
And then that's true. And I think that's probably one of the hangovers left from COVID, because all of a sudden nobody was being seen in practice.
Yeah.
They had to manage their leg ulcers themselves. They were given bits of paper to say, this is what you need to do. And quite a few of the people that I see have never been able to get back in again.
No.
That, you know, that's a shame. And it could be partly because the patient doesn't want to. But you know, when they come to see me and I say, well, actually you need compression, sometimes it's, oh, but I don't like compression. And then we start again trying to explain why. And yes, your leg's deteriorated because actually you're not wearing it, you know, and then trying to find, you know, the solution that suits them. And it is really important. And I know a lot of colleagues say there isn't time and the formulary doesn't allow it. We've only got so many garments allowed on you know, this type, and this is a one size fits all. And that has to be dealt with. And hopefully with the National Wound Care Strategy and the work they're doing, things will open up again. Because we were almost there. Remember, years ago, we had a conversation. We're almost there. Leg ulcers are really at the fore. It's really interesting. People are actually talking about it. We're going to get there. And then pressure ulcers arrived. And everything went the other way, which is sad. And then COVID arrived. So we start again.
Absolutely. We'll get that out there. Remember, did you have your hand up?
Yeah, actually, I have a question and also a comment. But the first of all, I fully agree with Dr. Adam and also what Helen and Susan mentioned about the compliance with the patient. Self-management is crucial. And in my role as in a global role, I work everywhere in the US and in the Middle East, in Asia. And regardless the level of awareness or educations or knowledge, or even the coverage from the healthcare system, compliance, it's actually a global issue. So even sometimes patients are actually lying about their compliance. I had my own personal experience with my late mom. She was always saying to me, yes, I'm putting the compression, but she's not. But, you know, the patient, because they are not feeling comfort or they are not really trained well or many, many reasons. And this is now my question to you. When the patient admit that they are not compliant, they are not putting the compressions, what actually the main objections that you hear from them? Because if we are talking about evidence-based, you know, we just recently done a study with Professor Hari Krishna in Malaysia, with a very big randomized study about the leg ulcer and using the inelastic wraps. And it shows that with the very complicated venous ulcer patients, the healing can be really accelerated from 6 months to 6 weeks. So you can imagine how it relieves the system, the healthcare systems, that change the lifestyle of the patients, the caregiver around the patient being family members or nurses and so on. So what, from your experience, what are the main objections or the main issues that your patients, and this question for three of you to learn more about how you face it in reality, and what kind of answers or help you give it to them?
I think for me, it depends on the age of the patient. And so everybody comes from a different point of view. You know, the younger ones have a life to live. There are things they want to do, and they don't want bandages on their legs. You know, having to wear the same shoe because it's the only one they can get on, and they have to wear it day in, day out. and it's about image and things like that for them. And dare I say that, you know, relationships and having that on your leg when you're trying to have a relationship with your partner, it's not really conducive. When you get then to the slightly older group, it is about being able to put it on. Also, I think in the past, nurses have been maybe not as great. You know, they turn around and talk about Nora Butty stockings. They're, oh, we got it. You can come out your bandages now, love. We're going to put you into your Nora Butty stockings. I mean, that's a really good selling point, isn't it? We have to sell it to them. We have to explain it to them. We have to show them what's available. And I just think prior to, you know, wraps coming on board and different applicators, all we had was bandaging and stockings. And then, I don't know if you remember the good old days, Helen, when all we had was American tan or black.
Yep.
You know,
And the nice NHS suspender belt.
Oh yes, yes. And yeah, I have a few stories about the suspender belt, but maybe for another time. Okay.
Great. Dr. Adam, also from your side, what kind of objection?
So I see a lot of patients that have struggled in the community and the legs are getting worse. And by the time they reach me, the common complaint is it's too painful to wear compression. And I try and explain to them that if they can just tolerate the compression for 1 week, once the leg goes down in size, just a little bit, a small amount, then the pain should go away. And then it might become quite comfortable, and quite few that get through that first week then come back, and I see them at a month or so, and they go, oh, I actually quite like the stockings now. They're quite comfortable. And I also explain to them, the other thing they don't understand is I say every minute that you're sitting, because we spend 70% of our daytime sitting, so that every minute that you're sitting with your legs down is damaging your skin in these patients. And they don't understand that. And so they just think they can sort of wander around for the morning, have breakfast, whatever, if they're not going out. And then they put the stockings on when they go out, which they have to be quite religious about doing it. And I think, again, the other complaint I see is that they can't get it on. But actually, if they allow the legs to balloon in the morning, they'll find it much harder to get the stockings on. So they have to get the stockings on straight after their shower in the morning. And so those are the two things. There's one, difficulty of application, and two, the pain.
I mean, do you think sometimes the pain is due to the fact that they've been given British Standard, which isn't straight, especially if they've got a history of edema? So the British Standard then folds across the front of the ankle, and that cuts in.
It cuts in around the knee as well, doesn't it, often?
Yeah, I definitely, I think that is the case. And if they're struggling with that, then I'll try and convert them into a wrap and just say, just for the first week, have it on lightly. Just put it on and just get used to wearing it and wear it lightly. And then after a week, just start to tighten it up a bit and work towards that. Or I say to them, you know, if they just cannot tolerate any compression, I just say, right, well, just start with some flight socks, some light socks that you can get from most places, and just start with those and just have very light compression and just start to get the legs down and start moisturizing and just start coming, basically start very gently.
Yeah, I think sometimes it's softly catchy monkey approach, isn't it? I mean, I've even, for older ladies, you know, we've gone with the old M&S support tights or pop socks to start with, just to get them having something, and then you slowly work up.
Yeah.
And then they don't realise you've got them into full compression before they know it, and they're like, "Oh, I quite like these." You have to be quite devious on occasions, I think. Really.
Yes, we do.
Thank you so much. That was so insightful from all of you, and I really do hope that anyone watching this event will take some of what they've learned today into their practice, you know, thinking about the patient and giving them choice and early compression and patient education and healthcare professional education. So thank you all for joining us tonight. Remember, was there any other questions?
No, actually, from my side, I was about to say this is the golden advice, what Dr. Adam said, that we always give it to everyone. Put the stocking on in the morning as possible as you can before the swelling or the edema start. Then it's much easier, it's less painful. There are different donning aids can help you also to use the stocking. So I think they need just to ask to see. There are so many nice educational videos how to make it really easy to take care of your legs, because I always say save a leg, save a life. It's as my personal experience, which I shouldn't mention that much, but my mom passed away with a DVT and PE and in the hospital, and of course everything happened with time, but I always have it in my mind compression could help her, but she was saying to me, yes, I'm putting the compression, but she's not. So people sometimes underestimate how crucial and important putting the compressions and how this can really affect their lives. And I think also people around the patient sometimes need also to learn, then they can support and help. So I have seen this also in some countries, that they educate the people around the patient to make sure that they really help them, try to push on them also to put the stockings and take care of their legs. 70% of the blood flow on the legs the whole day. So this is really something really you need to understand the importance. It's not just the socks. It's something can really help them a lot to have better lifestyle, improve their cases, and also save lives sometimes.
Yeah. Okay, well, I think that brings us to the end of our talk. So thank you all for attending. And we do have lots of resources available. So you can contact us via like LinkedIn or through MOH, and we can share our resources and our educational resources for patients and healthcare professionals too. Thank you.
Thank you.
Thank you very much.